Hello, and thank you for joining me for this presentation about medication and breastfeeding. My name is Wendy Jones, and I have a background in primary care pharmacy. I am also a qualified breastfeeding supporter, and many years ago I had this bright idea of putting the two roles together and looking at breastfeeding medication. That was back in 1995, and I was asked to update a currently available leaflet, which was just one A4 page. I sat in a community pharmacy doing a locum. The pharmacy happened to be a homeopathic pharmacy, and nobody wanted to speak to me, and I didn't know anything about homeopathy, so I had 2 weeks to spare. So I sat down and wrote the information that was available at that time. Basically, the only resource that was around was a small card made by Boehringer Ingelheim at the time. As a result of writing that leaflet, I decided I wanted to do a PhD, and I looked at the experiences of mothers, doctors, and pharmacists in a matched area. And unsurprisingly, their opinions on compatibility of drugs in breast milk weren't always the same. Some thought that breastfeeding was really important, others didn't think so. Some mothers would do anything to avoid any medication, others just wanted to get on with their lives. Since 1995, I've learned a great deal and life has changed considerably. I set up something called the Drugs in Breast Milk Helpline for the Breastfeeding Network. And it was originally a telephone line, and then it became one operated via social media. 3 years ago, I handed it over to a group of 25 pharmacists and began to recapture my life. This presentation will, I hope, just give you a glimpse on how to make the evidence-based decisions and how I've provided some information to save you time in busy consultations. We know that breastfeeding affects the use of medication. I've already said some mothers won't take anything because they want to preserve the purity of their milk. But around 80% of formula feeding mothers have taken some drug whilst feeding their baby, whilst less than 66% of those who are breastfeeding have taken something. This came from research from my PhD published in 2000 and from a piece of research in 2004. I actually think it's probably rather dated now, but nobody seems to have replicated it. Unsurprisingly, most of the medicines are taken in the first 5 days after delivery, and it's analgesics, antibiotics, laxatives, the common sort of things that we would expect. But with increasing C-section rates, we're seeing a lot more opioid use. So are the risks of taking a drug during breastfeeding the same as they are in pregnancy? We know we want to avoid as much as we can anything in pregnancy because of risks of thalidomide. But Anderson, back in 2003, looked at 100 case reports where there was any mention of an adverse reaction due to a drug taken by a breastfeeding mother. There were none that were considered definitely linked. Possible, probable, about equal amounts. The drugs that were causing most problems were usually CNS depressants, and anything that crosses the blood-brain barrier is more likely to cause the baby to be drowsy. So there were 3 fatalities during this Anderson found during his study. One was a mother who was given phenobarbital to control her epilepsy, and the baby subsequently died because phenobarbital passes very readily into breast milk, but not something we would normally be using now. Another was a mother who had been using methadone, but at post-mortem, the baby was seen to have multiple indicators of neglect, and it wasn't actually the drug that was responsible for the death. And another was a CNS given to the breastfeeding mother where the baby had already had a near-miss sudden infant death. Most of the babies in the case reports were younger than 2 months, but I've found over the last 25 years that most of the queries I get about can I take this drug while I'm breastfeeding relate to babies older than 6 months. Anderson concluded that actually taking medication shortens the duration of breastfeeding, sometimes because we're being overly cautious about what we know. And for many of us, myself included, I had nothing at undergraduate level about how drugs pass into breast milk. So we are on the side of caution because there is an alternative. There is formula milk. But we can also have very subtle body language. Comments in my PhD included things like, well, I wouldn't let my wife take that if she was breastfeeding in your situation. So what are the barriers to prescribing during lactation? And the biggest one of all is the license. And us as prescribers, I'm an independent pharmacist prescriber myself, having to take responsibility. One of the things I've always advocated is writing down in your patient notes the conversation that you've had, the information that you've shared with the mother, so she is empowered to be part of that decision making. All patient information leaflets in their boxes will say not to be taken if you're breastfeeding, or consult a professional if you're breastfeeding. And the written word is really powerful. The BNF has actually changed its stance quite significantly in the last 10 years and will now quote specialist sources. And the predominant one of that is UK Dialysis, which is part of the Medicines Information Service operated by the NHS. I think the biggest barrier for all of us is time to access specialist sources. We've got that very limited period from when a mother walks through the door, understanding what her problem is, deciding what to prescribe, filling in the notes, and getting her through the door. So over the last 25 years, I've summarised a lot of the most commonly asked questions. So there would be things like pain relief, antibiotics, laxatives, things that you see all of the time that you can just pull up and find the answer. We know that breastfeeding has many, many advantages for the mother and child, but we're always cautious that we're actually prescribing to both of them because some of the drug will pass through breastfeeding. But there are many cases where mums don't actually tell us that they're breastfeeding, and it might be an older child, or it just slips everybody's mind. Do we remember to ask? That was something that came up very much in my research, that people weren't asked, either doctors or pharmacists, and that prescribing decision went out without full disclosure. When I first started doing my PhD, I said very carefully to my supervisor, I don't want to do anything about pharmacokinetics. That's too difficult. I can't manage that. And yet now it's something that I do every day of the week. And I'm going to give you a bit of a whistle-top tour, and I apologise if this feels like I'm teaching my grandmother to suck eggs. It's just a quick revision. We also now have something set up by the MHRA called the Safer Medicines Consortium, and that is an attempt to make all prescribing decisions have a facility for the mother to understand what the risks and benefits are to her and our baby, and I'll say a little bit about that more later on. So how do drugs pass into breast milk? Predominantly, it's just by passage through across the cell membranes. In the first few days, the gaps between the cells are quite wide in order that the immunoglobulins in colostrum can pass through into the baby's system and protect the baby's guts, bladder, kidneys, and all are responsible for all the other benefits of breastfeeding. But once mature milk comes in, these gaps close off, and now the drug has to diffuse across the cell membrane, which is much more difficult because there are so many layers, and it depends on fat solubility and things like that. Pharmacokinetic are dependent on certain data, which you can't find in the BNF, so we can't make the qualitative decisions. The first thing that is relatively easy to make a decision on is about the molecular weight of the drug, which controls its oral bioavailability. So something like gentamicin, which has 0 oral bioavailability, cannot be absorbed by the baby through breast milk. So it doesn't matter how much dose mother is having, then the baby won't get any. It also is true of the new biological drugs. Basically, anything that is only available as an injection and not at all as an oral medication, so not IV antibiotics, but meropenem, something like that, won't get through it into breast milk. So these we can prescribe quite happily, even though things like the new biologicals are so strong they might feel quite scary. The other thing that's really important is the amount of the drug that is bound to the proteins in the mother's plasma. So ibuprofen, for example, is 99% bound onto the plasma proteins. So there is only 1% that can possibly get into breast milk and still has to go across all those other barriers. Sertraline is 98%, and these are the drugs that we want to prescribe if we possibly can. We want to prescribe drugs with short half-lives because otherwise they can accumulate in breast milk. If a mother takes a second dose of the drug within the 24 hours, she still has a very high percentage and it will increase levels. So this is true of things like fluconazole, which has a half-life in babies under 6 weeks of 72 hours. And very rapidly we can get side effects in the baby. Additionally, anything that is licensed for a child will be compatible with breastfeeding because the amount that is licensed for the child will be significantly higher than the amount passing through breast milk. So I'm thinking of things like loratadine, cetirizine, the antihistamines that mothers may be taking all summer. But where can we find this information quickly? I'll give you a list of resources later, because, as I've already said, this data isn't in the BNF and you have to go to specialist sources like medications in mother's milk, which I believe a copy is being provided in each practice for you, courtesy of Stacey Solomon, your infant feeding specialist lead. Some people suggest that timing drugs and feeds can minimize a drug level. So if you take this drug first thing in the morning and you don't feed until that night, the amount of drug will be significantly reduced. That's true in acute courses if the baby is willing to not feed for that length of time. Babies don't feed on demand. Your demand, they feed on their own demands. So asking a mother to wait can cause lots of problems. If any drug is being taken on a chronic basis, it reaches a steady state after 5 half-lives, generally around about 3 days. So timing then becomes absolutely pointless. And I've seen many cases where women taking antidepressants have tried so hard to take the drug last thing at night, which then interrupts their sleep pattern. But what if the baby is ill and waits to feed during the night? What does she do then? Can she not feed the baby? What's the risk to the baby? It causes so many problems, and it's kind of not taking into account all the other pharmacokinetic basis. So, as I said already, sertraline is 98% plasma protein bind. There is no reason to try to time the feeds. Pumping and dumping of breast milk is one of the things that I hate hearing. Dumping makes it sound that it's completely valueless. And as a breastfeeding mother in the past, throwing away this most precious substance is quite heartbreaking. And especially when we've been told how valuable it is liquid gold. So if we're not sure of the answer, can we suggest to a mum that she pumps but saves the saves the milk until such time as we've been able to check out the information? It may be to make a phone call, it may be to look up a resource, it may be to talk to colleagues, but don't just tell them to throw it away. Milk supply is not a tap that can just be turned off. So these are resources that I'd recommend for you. There is a website called LactMed, which was made by Phil Anderson, the gentleman who did the original research about harms of breastfeeding. It's free to access. It tells you in a little summary box at the top what the general information is, and it goes through all of the studies. And mothers can access it as well. It's written in a quite user-friendly message. UK Dialysis, as I've already said, is part of the UK Medicines Information, and you can find a lot of their information on their website, or you can contact them directly, and they will do searches specifically, or they may have the knowledge at their fingertips. Hail, this subscription is being given to you already. The fact sheets from the Breastfeeding Network and from Breastfeeding Medication are ones that I have largely written and are available free of charge, again, for you to share with the mothers. A lot of mothers on social media now know about them, so don't be surprised if they actually come into the surgery with them. So the only thing that would cost you personally to look at would be the Hail, but as I say, you are being provided with a copy of the book. So I'm going to look now at some specific examples. Mastitis is probably the one thing that we learnt about at an undergraduate level. It affects quite a large proportion of women, particularly in the first 6 weeks of their lactation. But it's not necessarily an infection. It's the milk leaking out of the milk ducts when they become too full into the surrounding tissue so that the body regards it as a foreign protein. It usually happens when a feed's been missed or where mum's gone out somewhere and worn an underwired bra that's caused damage to the breast. Sadly, it's often caused by domestic violence as well. So a punch to the breast could also cause that, but also can a knock by a toddler. So first of all, even if you decide to prescribe, I would suggest that you refer the mum for breastfeeding help. And Stacey is available locally, and there are a network of other people around who can work with the mum directly to make sure that she's draining the breast effectively. Ibuprofen works brilliantly as an anti-inflammatory to relieve this inflammation. And it has been suggested that this is the way that antibiotics actually are working, not by treating the infection, but by treating the inflammation. So depending on the patient that is in front of you, you could watch and wait to see if the symptoms improve with effective drainage. The antibiotics recommended by the WHO are Fluclox, erythromycin, and cefalexin, usually a 7 to 10 day course of high dose. We don't want to prescribe antibiotics unless we have to, part of the guardianship of antibiotics. But there are some women who I'm sure will have met, where you just look at and know that they are seriously ill and there can be a rapid risk of sepsis. So trust your gut feeling. In all of these slides, I've added a link to some of the information that might be helpful in this situation if it's of benefit to you. So the antibiotics that are compatible for breastfeeding are actually pretty much all of them. I can't think of one antibiotic that it would be necessary to interrupt breastfeeding to take. Most of them are licensed for pediatric use. So, as I said earlier, those would always be compatible with breastfeeding. Metronidazole, we used to say, would change the taste of milk, but I've been unable to find out where this originally came from. And I wonder whether it came from the fact that flagyl used to have a bright yellow dye in it, some of which came through in breast milk. And somebody somewhere looked at it, having expressed some, and said, "Ugh, that looks disgusting. I bet it tastes horrible." And that became fact. But I have no idea. There seems to be no information. Most babies don't bat an eyelid about it. Those that are bothered, apparently, if the mother eats extra garlic in her diet, it masks any unpleasantness. So, if she'd like to make a spag bol that night with lots of garlic in, that would be fine. We want to avoid Cipro whenever possible because given directly to juvenile rats, it causes a type of arthritis. This hasn't been seen in the levels passing through breast milk, but for many reasons, all of which you're aware of, we want to avoid it if possible. Macrolides are all compatible. There was some information that they could cause significance about sort of reflux, but the research doesn't seem to be behind this now. Doxycycline is actually chelated by the calcium in breast milk, and we know courses up to 3 weeks don't affect breastfeeding babies, so we don't have to worry about them staining the teeth or damaging the bones. But we would want to avoid tetracyclines for things like acne or similar conditions where they're taking them long term. Gentamicin, teicoplanin, the antibiotics that are only given IV are compatible. All of these drugs will knock the tops of the villi off in the intestine. So the babies do become temporarily lactose intolerant, which is why they have very runny nappies. It is a self-limiting condition. They don't need to do anything. You don't need to give them probiotics. Breast milk contains all the factors to return the gut to its normal state. You may need to reassure mums that actually they're not passing on any infection through their breast milk. They're actually passing on antibodies to protect their baby. When we're looking at analgesics, this is probably the question I get most often. I've seen so many cases where women have been told you can't have a stronger pain relief unless you stop breastfeeding, and that's quite inhumane, in my opinion. If we're going up the analgesic tree, we can give paracetamol. All the non-steroidals are highly plasma protein bound, so ibuprofen, naproxen, diclofenac are all compatible with breastfeeding. If possible, the next safest opioids are dihydrocodeine and even oral morphine. The amount that gets through in breast milk is very low. Dihydrocodeine is not metabolized in the same way as codeine. In Canada a few years ago, there was huge controversy where a baby died from a mother taking cocodamol. She'd had a C-section. She was given cocodamol 3500, and she kept going back to the baby's pediatrician saying, the baby's very drowsy and I feel awful on this drug. So the pediatrician said, you're just not feeding the baby properly. Go and see a lactation consultant. But he did reduce it to 500 milligrams. Continued, and the baby was feeding poorly throughout. And on day 14, the baby died. At post-mortem, they found multiple high levels of the codeine because the mother was an ultra metabolizer and had concentrated morphine into her breast milk, and that's what had killed the baby. Oral morphine, oromorph, is actually subject to extensive first pass metabolism, so the amount getting through into breast milk is different. So that's a different case to codeine. We don't want to prescribe codeine to breastfeeding mothers, and if possible, the same is true for tramadol, because those who are ultra high metabolizers of codeine may also be the same for tramadol. And particularly if you are prescribing in the early postnatal period, don't forget laxatives with the opioids. The mother may have stitches or a C-section scar, and the last thing we need is for her to be constipated. All of the opioids are compatible. All of the laxatives are compatible with breastfeeding, and stool softeners could be invaluable. 1 in 20, at least, of breastfeeding women, or of all women, will have depression or anxiety after birth. In an ideal world, we'd refer them all to CBT therapy, but I know the waiting lists are becoming longer and longer and longer. I have a daughter who is a CBT therapist, and no matter how hard they all work, they just can't reach the bottom of the lists. If you feel that a drug is necessary, if she's had one in the past, prescribe that one again, because having had it in the past and finding it effective is halfway towards resolving the symptoms. If not, the list that I've put up there is probably in the order that I would prescribe them, simply on the amount that gets through in breastfeeding. I've put paroxetine at the bottom because although very little gets into breast milk, it's very hard to come off of. It has strong discontinuation problems. So it would be my least drug of choice. But the amount of drug getting through into breast milk is very low. Babies can behave differently because they're going to anyway, but it may be that the mum's anxiety is looking for something going on that is actually part of her condition, looking for something, being anxious about what she's doing. Anti-anxiety meds are really hard because if we're prescribing an SSRI, we know they're going to be 4 to 6 weeks before they're fully effective. We might want to prescribe a short-term benzodiazepine. And I know a lot of the psychiatrists say if she could just get a decent night's sleep, then she would feel much better. But the trouble with prescribing hypnotics is that they will cross the blood-brain barrier and can cause the baby to be drowsy. If we tell her not to breastfeed overnight, then we risk her getting mastitis because she's missed feeds, or she has to get up to pump her milk, in which case she might as well have fed anyway. What we really need is somebody caring to look after the baby. Just bring the baby to her for feeding, take it away again. So maybe grandma, dad, aunties, sisters, somebody else may be available. We want to avoid diazepam because it's had this very long half-life. Lorazepam is much safer. We may need to go to the higher drugs like venlafaxine, risperidone, but they are all compatible with breastfeeding as well in normal standard amounts. There is a piece of research from 2015 that actually it isn't breastfeeding that causes depression. The risk is of women who planned to breastfeed but failed, in their terms, to be able to do so. They have a level of guilt. They feel that they've not been the best mother. all of these sort of things. So if you see a mother who is actually having some degree of depression or anxiety and is struggling with breastfeeding, then please refer her for additional breastfeeding support so that we can help her to achieve her goals or be satisfied at least that she did the best that she can. We don't want to stigmatize anybody for not breastfeeding, but we want them to support them to achieve their goals. I've already mentioned loratadine and cetirizine. All summer long, we always get questions about what can I take if I'm breastfeeding. One of my very early calls was from a mum who just said, I just need to stop. Can I take one of these drugs to stop me breastfeeding? And when I asked her why, it's because my hay fever is so bad, I cannot be an adequate mother unless I can take some antihistamines. So I must stop breastfeeding. Actually, all the standard antihistamines are completely compatible with breastfeeding. Nasal sprays, eye drops too, work wonderfully and are only acting locally. So again, whatever the mum finds most useful for her is fine. We want to avoid the sedating antihistamines like chlorpheniramine. Bizarrely, there is actually no data on the amount that gets through in breast milk, although it's licensed for children. Nobody seems to have done the studies, but it can make the baby drowsy and then result in a decrease in milk supply because the babies aren't feeding as effectively. At this time of year, I'm recording this in January, I'm sure you're getting people who are wanting to stop smoking. Lots of mums quit smoking in pregnancy because they're aware of all the risks about the baby not growing as effectively, and midwives do a wonderful job about persuading them to stop. But many of them go back to feeding afterwards. Why? Because they want 5 minutes to themselves to mask their hunger. Breastfeeding makes you hungry. Maybe they have not got financial resources to eat as well as they should. Um, Maybe it's just a calming thing for them because they've smoked for a long time. It's part of their way of living. It could be that it's very normal in their social group or their family. So how do we help them? The risks of smoking during breastfeeding cannot be underestimated. Most cases of SIDS now relate to the mother smoking or having alcohol. If both parents smoke, the risk of SIDS, although very low, is multiplied by 7. It can cause colic in the baby if the mother is smoking. We don't really know why. Is it about the fact that it's lowered prolactin, so there is less milk? They've slowed their letdown, and that may cause them to wean earlier. But they're also more likely to visit you with respiratory infections and allergies in the babies. And then we've got things like LDL and the long-term effects on the baby. So we really want them not to be smoking if we can possibly manage it. You can tell I ran a smoking cessation group at one time. We want to use the drugs that are most effective. So assuming that most people will have tried the nicotine replacement substances or have vaping, maybe we're going along things like bupropion. In America, it's widely used to treat depression. Um, the amount getting through is probably minimal. There's one case report of a seizure in a partially breastfed baby and maybe totally coincidental. So it's not a reason not to prescribe, but be careful, obviously, if the mum has had any problems, adverse effects in the past herself. For inner cycling, has much less data on it. And this isn't one that we would want to prescribe, if possible, because there is something about infant lung development. Um, so if you've got a choice, this isn't the drug that I would be picking. E-cigarettes, we know, are becoming increasingly popular. Um, the amount of nicotine transferring into breast milk from the use of e-cigarettes is probably minimal and very much less than actually smoking. But we actually are probably underestimating the amount that people are inhaling. But at least it's cutting down all the other chemicals in the smoking process. I was asked to include a slide about street drugs. I assume that there is a problem in your locality. Cannabis obviously is one of the most common ones, and I come into a lot of conflict with American colleagues where in some areas its cannabis use is legal. The amount that gets through in breast milk is very low, but it is fat soluble and can accumulate in the baby's brain. It has quite a long half-life, and we have absolutely no idea what it is going to do to these babies in 10 to 15 years' time. So if they can cut down, and certainly not to be using it regularly, that's much better for both of them. It's really difficult not to be judgmental in these situations. Think, why would you expose your baby to something like this? But for many of them, again, it's part of their lifestyle. I was always surprised when I was running the drugs in breast milk service, how many Monday mornings would come up with a message saying, I use cocaine on Friday night, and a lot of alcohol as well. I know I shouldn't be breastfeeding my baby, but how long do I need to stop for? The minimum period is 24 hours, but ideally it should be 72 hours for it to have cleared from the mother's system. Again, this seems to be a recreational thing. I've seen mothers with 2-week-olds who have gone out and snorted cocaine. Did I say cocaine? Cocaine. Benzodiazepines, the diazepams, the temazepams, they are going to hang around. They make the baby drowsy, so it's something to be aware of. Ecstasy, after 12 hours, the levels in milk are low. If they're feeding before that, the baby can exhibit the same symptoms as the mother can. We actually don't have any data on heroin, but the cases that I've come across, the mothers haven't been able to sustain breastfeeding because of their erratic lifestyles anyway. But mothers who are put onto a detox program using methadone and buprenorphine can continue to breastfeed, and it may be a way of persuading them to stay clean and start a new life. For their baby, I had a mother and father who chose to move house away from all their old crowd, in order to give their baby the best start in life. And that was one of the most humbling experiences of my life, seeing somebody make those changes. But those drugs are completely compatible with breastfeeding. It may seem very simple to prescribe a drug to stop breast milk. Um, my daughter this year has had breast cancer, which is one of the reasons why this recorded version has been a bit delayed. And I've started to come across many women who are still breastfeeding when diagnosed with cancer, and we need them to stop quickly. We can give them drugs, but the drugs have quite horrible side effects. So they would be my treatment of last resort. It can also feel that it's kind if a mother's had a baby born sleeping or a cot death to stop her breast milk supply quickly. Actually, there's a lot of research now that a mother may find it beneficial to donate her breast milk in memory of her baby if the baby's been born sleeping or been lost at a late stage. And most of the milk banks are happy to take this and to support the mothers. Bromocriptine should no longer be used to stop breast milk production because there are a lot of serious adverse events, particularly in cardiovascular and psychiatric, and there have been deaths. Physiological reduction of the milk supply, just slowly dropping one feed at a time, is much better for mum and baby unless there is a reason why mum is desperate to stop straight away. And again, referring for local breastfeeding support may be the best way of achieving this. So drugs that might affect supply. And the one that most women will know about through social media, it seems to spread like wildfire, is pseudoephedrine that's in Sudafed. And one dose can reduce milk supply by 24%. So they've taken their Sudafed tablets for nasal decongestion, and their supply has just dropped dramatically. There's no evidence that phenylephrine does the same thing, but because it is drying secretions, it is logical to assume that it would do the same thing. There's also one report that if put up for licensing now, it would not achieve licensing because it's not effective. Early use of contraception can, for some women, stop their milk supply virtually overnight. So I know that there are a lot of campaigns to have a one-stop provision of contraception at discharge in the hospital, but the hormones are still trying to reach their new balance. And if we give progesterone at that stage, the supply may stop. Certainly if we give the combined pill less than 3 to 6 months, the estrogen is likely to work against the prolactin and stop supply. Anything which is a diuretic would reduce milk supply. I happened to get an email just this week where somebody wanted to take a dandelion supplement for liver toxicity that she decided that she'd got after the Christmas binges. Dandelion's a natural diuretic. So we want to avoid certainly furosemide, but probably bendrofluomothiazide as well. Aripiprazole is the new wonder drug in psychiatry, but in every case that I've come across so far, the mothers haven't been able to achieve certainly a significant milk supply, if any milk supply, if they've been taking it. So the mother needs to have that information in advance rather than be struggling afterwards. Anything that makes the baby drowsy, like chlorpheniramine, like taking Phenergan tablets to help mum sleep at night, can lower milk supply. But most cases of perceived low milk supply that you will come across are due to less than perfect attachment and drainage of the breast. You can't possibly manage to deal with that in a consultation. So please refer on to the infant feeding specialists in the area, who are all specially trained and more than happy to work with you to support these mums. When we prescribe off license, I feel strongly that this should be a shared decision between you and the mother. So she needs to know any potential risks from the drug. So if she's going to have codeine, what might happen? Does she need to watch out for drowsiness in the baby? The baby that died in Canada, the mother was saying all of the time the baby is incredibly drowsy. I know in our family, none of us can tolerate codeine. Our babies just sleep, but all of us would suffer any amount of pain rather than take codeine because it makes us feel sick, nauseous, as well as constipated. They need to know about potential side effects like baby having diarrhea or parent diarrhea when they take antibiotics. So, what to look out for, what's normal, and what needs to be reported. They need to know that carrying on breastfeeding is the best thing for her and her baby, and particularly strategies for dealing with relatives who can add negative comments. Um, Previous generations have not had good breastfeeding experiences and may say, but I fed you with formula milk and you're perfectly fine. That's not the message we want to be giving anymore. We want to be encouraging breastfeeding as a public health measure. But in the rare situation where she needs to interrupt breastfeeding, she needs to know how to maintain her supply and avoid mastitis. And then also when she can restart breastfeeding. One Easter, I had a mum who had been told by her dentist to stop breastfeeding while she was taking antibiotics. And she phoned me 10 days later again, well, when do I start again? We need to have that full cycle. And the best people that can help, the infant feeding specialists. That's why this session is being launched, to provide you with the names and the knowledge of how you can interlink. I asked on my Facebook page, what do mothers want professionals to understand about breastfeeding and about medication? And the first thing that came up repeatedly was, you need to understand how long it took and how hard it was to get to this point in my journey. Maybe they've reached 6 weeks and they've come for their postnatal check, but they've had to battle through sore nipples, sleepless nights, multiple visits to lactation experts until it became pain-free. And if you have a throwaway remark about, well, I need to prescribe drug X for you, and 6 weeks is good enough for breastfeeding. How hard that is to listen to. Breastfeeding matters, and it's about so much more than the transfer of milk. It's about the way that they mother their child, the way they get them to sleep, the way they comfort them. Those of you who have had babies who have been breastfed in your family, I'm sure will understand this. I certainly didn't understand it until I had children. You and they need the contact numbers for where there is more information, and it might be one of the charities, it might be a local breastfeeding drop-in group. And they wanted you to use evidence-based sources of information, not just the BNF, because the BNF is about the manufacturer not taking responsibility. It's not about true evidence. And if a mother brings some information to you, it shouldn't be just dismissed out of hand. It probably has come with the best intentions. And I know we all hate the internet patient who's done the searches and thinks they know more than we do. But if it certainly is one of the fact sheets that they've been advised to look at, listen. I think it was back in 2007 now, the original NICE guideline for maternal and child nutrition was a guideline group I sat on, and it actually has a recommendation that all professionals and pharmacists should be looking at specialist information and acknowledging that if mothers stop breastfeeding abruptly, then it can be difficult to reverse, and suggesting that additional information be looked at. So you actually are coming by NICE guidelines. We all stand by the first do no harm. but we need to remember that breast milk doesn't turn up off like a tap, and suggesting that breastfeeding is interrupted risks the mother getting mastitis, the baby possibly refusing to feed because it doesn't like the taste of formula, because it's never had a bottle, and bottle feeding is a very different technique to breastfeeding, and that if the supply drops, it can be very difficult to re-stimulate. So in trying to do harm, we may actually be causing harm. So, quick summary. We can use pharmacokinetics. We can look at this basic data, but we can also use specialist sources to check the data, to provide more information. We can support mums with expressing and develop a care plan for when they go back to feeding, and we can call in support from the infant feeding coordinator and others. And the overwhelming thing that I want you to remember is that most drugs are compatible with medication, or there is an alternative that is. So we may not be able to prescribe the newest, most whizzy drug that we've read about, but one of the older similar drugs can be just as good. If somebody has been discharged by the consultant and you're asked to continue their medication and you're unhappy about the information that you've been prescribed or the recommendation to take responsibility, there are people that you can call. UK Dialysis has a direct phone number and an email. BFN, there are 25 pharmacists there who will provide you with the information on the compatibility and help you to make that decision. Or you can email me. If it matters to you and your patients, it very definitely matters to me. So we can use evidence-based information, and we can be sensitive to the needs of mothers about infant feeding. Thank you for listening. I hope this has been valuable. If you have a question, please feel free to email me, and I hope the resources are useful. Thank you.